Yeah. Okay. Thank you.
You're welcome.
So Nicole, we go way back, I guess, to the idea that the Mass Nurses Association should organize Bay State Medical Center. I think maybe we met
From your
there.
lips.
Yeah, what I learned is that the MNA has only one researcher, and from the way that she does her job, they may not need any others. She would disagree, but we have constantly been tutored by Nicole on how these hospitals work, especially how they work in the Cayman Islands. So, do you want to take? Do you want to share your screen at all? Do you have anything you want to? Because I made you a co-host. You can just take it away for a little
Okay.
while, and then she agreed if you didn't hear already that you could throw a question into the chat as you're listening, as it occurs to you, and she'll get to those. And then, of course, when she's done, she'll take questions again. And here comes somebody. But go ahead, Nicole.
Okay. So I'll share my screen. See how this works. And I'm even kidding. Okay. That looks good. Okay. So what I thought I would do today is present some information that I think, some of it will be intuitive. Some of you as medical providers, nurses will, know a lot of this stuff, but I wanted to provide some context for how hospitals are making money and spending it. So first, there are 4 types of hospitals in Massachusetts. There are I'm just going to admit people as they come.
I can do that for you. You don't have to worry about it.
Okay.
Kimberly or I will do it.
Sounds good. So community hospitals are not teaching hospitals, and they have less than 63% public payer. So more private health insurance is what's going on at these hospitals. But a high public payer community hospital, so that's a community hospital that just has a higher percentage, 63% or more, of Medicaid and Medicare patients. A teaching hospital has a certain requirements around the number of medical residents that they have on staff. And then the academic medical centers are really more specialized hospitals that offer, they're technically and usually connected to a medical school. And then they also offer more tertiary and quaternary care. And so, but a subset of these are the for-profit hospitals in Massachusetts. And these for-profits own a variety, or owned in some cases, a variety of community, high public payer, and teaching hospitals. So right now, we have one for-profit entity that owns hospitals in Massachusetts, which is Tenet Healthcare. They are publicly traded. They operate 3 hospitals, St. Vincent in Worcester, as well as Framingham Union and Leonard Morse. That's part of the Metro West Medical Center. Because it's a publicly traded company with shareholders, their primary focus is profit. And I would say that if you look at, the financial records of hospitals across Massachusetts, whether they're for-profit or nonprofit, their primary goal is making money. But a Tenet or a Steward, these are ambulance. These are a different focus on making money that is really like to the exclusion of all else. And Tenet, if you've been reading the Boston Globe at all, you'll know that Tenet Healthcare, which again owns St. Vincent and Worcester, has been really coming under attack from us at the MNA, the nurses in the hospital, and elected folks, because there's been such a horrific rash of patient harms and even more extreme cases of patient deaths because of the short staffing in that hospital. So for a while, we had 2 for-profit entities operating in Massachusetts, and the other one is, of course, Steward Healthcare, which you all know about, given the white paper. So Steward was initially owned by a private equity company, Cerberus Capital Management, which is based in New York. Eventually they sold to Ralph Delatorre, the president of Steward Healthcare, and his medical executive partners. But between the time of acquiring Steward, or really creating Steward and selling it off, Cerberus managed to extract, my guess is billions from Steward Healthcare. I would look at their financial reports year after year, and I'd see these hospitals, these community hospitals that really looked like they were struggling. With the negative margins every year, with claims from Steward that they just didn't have the money to operate these facilities. While at the same time, you could look at the money leaving the community hospitals and going straight into the coffers at Cerberus Capital Management. So, that was a nightmare. They also sold off a lot of the properties to a real estate investment trust. They eventually ended up in bankruptcy, permanently closing 2 hospitals and then selling off the remaining 6. So now we know what kind of hospitals we have here. How are they making money? So again, this next set might be something you know quite a bit about. The first revenue source, and the largest for most hospitals, is from CMS, the Centers for Medicare and Medicaid. That tends to be the bulk of reimbursements at hospitals. The second, commercial payers. So these are health insurance companies that reimburse hospitals for services. And what's interesting about commercial payers is that their reimbursement mechanism is really applied unevenly. So you could be a community hospital that is owned by an independent or, a smaller healthcare organization, and that community hospital for the same procedure will get a lower reimbursement rate from Blue Cross Blue Shield than, say, a community hospital operated by Mass General Brigham. And that's just because MGB has more power in the state, more room to negotiate and push Blue Cross Blue Shield to offer larger sums of money for the same procedures. Another source of funding for hospitals is NIH funding or other federal research grants. I imagine we'll see some changes there. Who knows? Investments, for-profit entities. So this is an interesting one. And there are a couple of ways this works out. So hospitals will often operate a for-profit entity, like a real estate company, like a senior living community. In the case of Bay State Health in Springfield, they operated a for-profit health insurance company for a while. So this is a way that nonprofits are having certain business lines that are really simply about making money in the most explicit way possible. And then, I put CARES Act here because while the CARES Act is COVID funding and it's not ongoing, it really was a huge moneymaker for hospitals between 2020 and 2023. The CARES Act offered hospitals usually increased reimbursement rates, grants, loans, things to offset what they expected to be losses from COVID that hospitals would experience. And the shocker is, despite all of the rhetoric to the contrary, when you look at the financial reports, almost every hospital in Massachusetts made money every year of COVID. You'd see a quarter where they'd go down a little, but then whoop, they were right back up. So the CARES Act helped with that, but they also, laid off a lot of staff and did a lot of other things to save and store money. So the next thing I wanted to talk about is, in addition to the regular reimbursements that hospitals get for providing healthcare, there are some ways that hospitals save money and cut costs. So the first, and I think most egregious and dangerous, is understaffing. So obviously it's a lot cheaper to have one nurse take care of 4 or 5 or 6 patients than to hire more nurses to take care of those same patients. And that's just the number one tool in the toolbox for hospitals across Massachusetts. They will do anything they can to avoid hiring nurses. And one of the ways they've done that is to hire travel nurses. This sort of exploded during COVID, but these are nurses from all over the country who have very different types of licensure. So coming from states with less rigorous licensure than Massachusetts. And, you know, most of these nurses are wonderful, capable nurses, but they're also cheaper. You can pay an individual nurse a lot of money by the hour, but this nurse also has no access to benefits like leave time or health care or retirement. And even though it's a huge cost savings for the hospital, I looked at the numbers, and in 2023, the percentage, the cost of travel nurses was $1.5 billion. So this is year 4, you know, post-COVID. We're post-COVID now, but we saw some increases in travel nurse spending in 2020 and 2021. And you would think that, you know, as 2022 and 2023 progressed, that some of those needs for travel nurses would be eliminated because the travel nurses were seen as a way to fill the gaps. That hasn't been the case. Hospitals have just discovered, oh, it's cheaper to hire these out-of-state nurses and not give them any benefits. So let's keep doing that. And between 2020 and 2024, hospitals have spent, excuse me, spent $4 million on travel nurses. So another way that hospitals are, you know, saving money is closing hospital units or closing full hospitals. Between 2009 and 2024, at my count, and I'm sure I'm missing some, we've seen more than 45 unit or full hospital closures. The hardest hit units or the hardest hit for closures were maternity units, pediatric units, and mental health and drug detox units. It's no accident that these services tend to be the lower reimbursing services. So they're not cutting the services that make them a lot of money. These hospitals are cutting services that are deeply important to individuals and to communities, but they're not the ones that make them money. So they get the slash. It's also the case that while these closures have targeted every single type of community and population in our state, from rural to urban, it's also true that communities with higher percentages of immigrants, Black and brown people, and low-income folks have been targeted and, I would say, harmed the most by these closures. And then the offshore accounts. Everybody likes to talk to the Cayman Islands, and I think it's because we all need a vacation. But you know, a lot of hospitals are, the majority of hospitals actually in Massachusetts put money in, they have captive offshore accounts, typically in the Cayman Islands, sometimes in Bermuda. And these are places where they say, like, this is our malpractice insurance money. We're keeping our cash here in the case of very serious malpractice claims. But, you know, it begs the question, why are they putting that money in the Cayman Islands when you could have that account in Massachusetts or any other state in the US? And they're not doing it because of taxes. These are mostly nonprofit hospitals, so they're not evading taxes. What they are doing is evading oversight. So they can sock away as much cash as they want in these offshore captive accounts and then have no state or federal oversight into how they spend them. All right, so we know how they're making money, how they're hiding money. Let's look at how they're spending. So the largest expense for any hospital is, of course, its workforce. And 43.3% is, in 2023, was the average figure for how much a hospital pays to cover staffing. Other costs like overhead and capital projects, or, you know, new MRIs or whatever, the things to keep the lights on and the services running, those are another large expenditure. But what I thought would be helpful today, because we can all sort of wrap our arms around what it would cost, or, you know, what the expenses are in running a hospital if we've ever been to one, and we all have. I think there are these other pieces, these other things that they're doing that we wouldn't necessarily think of, and those are the revenue generators. So I want to talk a little bit about those. So the first one, and this is so ambulatory surgery centers. This one is sort of, we all know what an ambulatory service center is. Most of us have probably had some kind of procedure done there over the years. But these are centers that are cheaper to operate because they typically operate only during the day. We only have day patients. Folks aren't staying overnight. There's a lower need for staffing. There are lower overhead costs. And they often tend to provide more lucrative services like joint replacement, which again is really, that the reimbursement rates for joint replacements are kind of the sweet spot for hospitals. Tenet, for example, has doubled, I think more than doubled the number of ambulatory surgical centers they've had in the last couple of years. And they now operate 544 of them nationwide. And when I looked at their finances in 2024, so the first half of 2024, so just 6 months, they had already made, Tenet had already made $1.8 billion just on this one service line. So that's not even, yeah, it's a lot. That's not even counting, the hospital services, which should be the dominant part of their business. But in Massachusetts and in other places, you'll also see everyday nonprofit hospitals also opening these surgical centers to sort of capture the revenue that they can't capture in the same way on an inpatient basis. And there's a trend of hospitals partnering, nonprofit hospitals partnering with for-profit entities to open both these ambulatory surgical centers and also mental health facilities. So a nonprofit hospital and a for-profit entity will get together and open a for-profit psychiatric facility, for example. And what's helpful to hospitals from a money-making perspective is that they can identify who they want to be patients at these mental health facilities. They don't have to be as available to Medicaid and Medicare patients as a typical acute care hospital would. So there are these ways in which, hospitals talk about expanding capacity by these outpatient ambulatory service centers or these new mental health facilities that is not really about expanding capacity, but more about expanding revenue. And then another thing I want to flag that we're seeing kind of take off in Massachusetts and elsewhere is hospital at home. And I don't know if you all have talked about this yet, but if you're if you're thinking that hospital at home is like a VNA, visiting nurse, this is a very different type of healthcare, a very different service line. So during COVID, there was a Medicaid waiver that allowed hospitals to send a patient home to get their care, but to consider them inpatient for the purposes of reimbursement. So a patient who, I don't know, I'm picking RSV because it's still winter. So a patient with RSV who typically would have been cared for in the hospital decides their acuity level is okay, so we're going to send them home. So they send them home. They're still considered an inpatient. So the hospital gets reimbursed every day as they would for a regular patient in a regular hospital bed. And then these hospitals are partnering with companies like Geek Squad to do the technology aspects of that job. So to go into a patient's home and like set up the monitors and the computers. These are, not healthcare professionals. These are folks who are professionals in their field, which is technology and not humans. So that's happening. And then nurses and other caregivers are being sent out into patients' homes to take care of them. And we don't know, obviously, how this is going to go, but it seems like because it's a way for hospitals to save money and rack up those high reimbursement rates without keeping patients in beds or as many nurses on staff. My guess is that, as with VNAs, you're going to see the acuity of patients who are taken care of at home go up. In the past, when VNAs sort of emerged, they've been around for a long time, but the modern VNA in Massachusetts, the way it's emerged more recently, is, they were to take care of people who were less sick, who were recovering, who were sent home. But the problem is, because hospitals are so poorly staffed and nurses typically don't have the time to provide, the adequate education that patients need to go home and get well at home, visiting nurses are often assigned patients. And so these VNA nurses are seeing much sicker patients at home than they did 10 and 20 years ago. And my guess is that the hospital at home service will probably also trend in that direction. And also, again, the hospital at home will rely on technology and fewer humans, and that seems a little bit scary. So that's a little bit of kind of forecasting, and I want to do just a little bit more about what I think we're seeing and expecting to see. So obviously, under Trump, the lack of oversight of both health organizations and health insurance companies will continue. CMS is being hollowed out. I wrote Kleptocracy Run Amok because the CEO of Cerberus Capital Management, Steward Healthcare's overlord, Steven Feinberg, has been nominated for Deputy Secretary of Defense. So that's scary. In Massachusetts, we'll continue to see a lack of state oversight and regulations. That's been a problem under every Democratic governor we've had. So not just the Republicans, it's a real issue. We'll see continued rising health costs. The Health Policy Commission keeps every year putting out like a certain benchmark for rising costs, and every year we eclipse them. So Massachusetts is, we're high achievers in lots of ways. And it's true that even in healthcare spending, we gotta break records. And then, the thing that I think most folks will really experience is at the local level. People going into hospitals today will not see their nurse as often as they ought to. They will be subjected to unsafe staffing levels. You're going to see ongoing reliance on technology instead of staff, whether it's pushing people into hospital at home, or whether it's having a remote caregiver from another state on a computer screen looking at a patient in a Massachusetts hospital for a lower cost. And I think we'll continue to see unit and hospital closures unless something dramatic happens. And that's the end of my uplifting presentation.
How about if you call on people if they have questions? I put a few in the chat. I didn't see any others, but anyway, why don't you keep the dialogue direct with you, and I don't have to worry about it.
Okay, so I can respond to your questions that are in the chat, John. So thank you, Michelle. So examples of for-profit entities. So I think I gave the Bay State Health example, or, oh, you're talking about not the partnerships, but the actual entities that nonprofits will own, right?
Yeah.
Yeah. So, I've seen this over the years, and I think it's changed a little bit. Like, some places will use these tools more than others, but in the Berkshires, I've seen Berkshire Health System, for example, ran several elder care facilities, and they were all for profit, just like a different service line, run for cash, no extra oversight, just a way to amass money. I've also seen several companies or several nonprofit hospital organizations that owned these small real estate companies. So sometimes this would be just like a company X as a part of a hospital system. Company X will buy a facility, and then the hospital might lease it from company X. It's a very weird relationship between the hospital and its for-profit entity. So it's kind of it's strange, and just another way to amass cash that isn't about the provision of healthcare.
When, as a follow-on, when Bay State owned an health insurance company, what was that called?
Health New England.
Health New England.
Yeah.
Was Health New England a for-profit?
So it was a for-profit that eventually converted to a not-for-profit. And at the time I was like desperate to figure out why and who and how. And I've never been able to answer that question, but it did operate for several years at least as a for-profit entity. Yeah. Which is crazy also because not only is this healthcare organization owning this health insurer, but also, Bay State is offering this health insurance plan that it owns to its workforce, and then nurses and CNAs and everybody has to buy into this one Health New England plan. So they're paying their own employer for their own health care in so many different ways. So it's really just a way to, in that case, and a lot of hospitals do that. It's a way to both, make money, save costs. Usually these are preferred providers. So if you are on the Mass General Brigham plan and you go to a Mass General Brigham facility, your costs are cheaper, which means the system is making more money on the backs of its employees. So it's a pretty complicated system of grossness. Do patients have any say about whether to be hospital at home patients? That's a great question. And I don't know. So right now we've just organized nurses at Mass General Brigham's, MGH's hospital at home. So that's a question I can ask them. I don't know. My guess is that it's really about acuity. And there are some upsides to being cared for at home, theoretically. There's a lower insurance, there's a lower infection risk if you're at home, but there are also all of these other factors like, that assumes that you've got somebody at home with you who doesn't have a job outside of the home, who can kind of take care of you and be your not nurse, but your caregiver in the absence of a healthcare professional. But I haven't heard anything about whether or not patients have an option. When does the nonprofit hospital risk their nonprofit status? Okay, this is so Lynn's asking about when a nonprofit hospital risks its nonprofit status because of the for-profit entities. From my perspective, the way the Attorney General administers the nonprofit status requirements for hospitals is a joke. In the past, when hospitals first in the US kind of emerged as things that weren't operated by churches or community organizations, but were independent kind of organizations, the notion of a nonprofit hospital was really because they'd be providing care for the poorest of the poor and the sickest of the sick, and it was like considered a social good. Over time that's obviously changed, and whether a hospital is failing to provide adequate services, whether people are being readmitted more and more and more, whether patients are dying because of poor staffing. There's so many things that you would think would impact their role as providing a social good, and in that way would threaten their nonprofit status. And I've just never seen it happen. I think the nonprofit status is, it's a joke. I think if we could figure out a way to really reinvigorate the idea of what being a nonprofit hospital is and what the regulatory requirements are to operate as one, I think that would make a huge difference. But so far there's nothing. MGB is the largest private employer in Massachusetts. What do we make of its recently announced layoff? Good question. I think we'll see. I mean, so we've seen layoffs so far of lots of management, both in Eastern Mass and also even here at Cooley Dickinson in Northampton. So far they're saying that that's unlikely to impact the caregiving staff. I doubt that. MGB has kind of been crying, some version of poverty for a while, and yet we still see them turn over millions in revenue every year. Yeah, I don't know. I mean, part of me thinks that a lot of companies are acting with kind of reckless abandon because they don't think there's much state oversight and they know there's no federal oversight. So, that's sort of like a wild guess, but I don't know. Sandy, if you have an idea, I'd love to hear what you're thinking.
Yeah, just are they running because they're afraid of the Trump administration's slashing of monies going into healthcare? Back in when Medicare and Medicaid were enacted back in '65, Old Man Frist and the HCA folks were gleeful because they saw a boondoggle in terms of money, public monies going into healthcare. In 1965, they had 4 hospitals. Within a couple of years, they had 200, across the country, either owned or managed, and they're made out like bandits. And in 2010, Old Man Frist, the founder, well, he had enough money to buy his son a U.S. Senate seat from Tennessee, but that's another story. He was quoted speaking to a Chamber of Commerce in Tennessee, bragging, announcing that this is a prime time for entrepreneurs to get involved in healthcare. So now this apparent cutbacks from the federal government, I'm just wondering if that's driving any of the, if you think it's a little early, but if that's driving any of the decisions being made, hunkering down ahead of that, or whether they're just slashing anyway for the heck of it.
I do think it's both. I mean, I think there will absolutely be some impacts on hospitals from this administration because they're so determined to hollow out the administrative state, and that has trickle down effects. So there's that. I also think it's an excuse that hospitals are using at the bargaining table. So, well, in addition to hospitals, we represent the nurses and nurse practitioners and therapists at Smith College. So here in Northampton, it's a small, very pricey private college with a huge endowment, and they're talking about their really dark fears of the Trump administration. So, and this is a health center that isn't even, it's owned and operated by the college, doesn't have anything to do with insurance. So it's really, I think employers are using it as an excuse to try to be tough at the table and try to convince nurses and other folks, other healthcare workers that, all is dire and they should just take what they can get and zip their lips. I mean, but that's also so, I know that's so dark. Maybe a little pessimistic. Oh, Shelley, yeah, that's right. Right, Cooley Dickinson, the same thing. So this is a hospital that's affiliated with Mass General Brigham, and they're trying to scare folks at the table. I've been there too, and make sure that they know that the hospital is probably going to be running into some real financial difficulty and that people should be scared and settle their contract quickly and take as little as possible. Right.
Nykole, can you go a little bit deeper into how or which hospitals are really real estate operators?
I don't have, can I do that now? No, probably not. I could probably get you a list if I spend some time on it. It's just something that I've discovered over and over again throughout the years of doing the research. And it's something that always, not mystifies me because you know why they're doing it, which is cash, but I can look and see if I can get you some of that info, John.
Well, I'm wondering about the general practice. Is it still commonplace? Because a lot of the hospitals, like Bay State, have acquired real estate, have done real estate operation only in order to expand. That's right. And then others have been accused of being slumlords and the whole 9 yards.
Right.
And do we have that going on in Massachusetts?
Yeah.
The worst of the worst.
Yeah, I'm not sure. I don't think I can give you a good straight answer on that.
Cool.
Any other questions or?
Peter's got his hand up.
Peter, yes.
Hi, Nykole. Thanks for the
And then-
presentation. It was helpful, but I have a bunch of questions.
Okay.
So first is a very basic question. How do you define acuity?
Oh, that's a great question. And that's a question we've been asking everywhere. I mean, I feel like Connie could answer this question, or Sandy. There is, I mean, from my perspective, or from what I've heard, there just is no answer. For example, when you're talking about moving people into hospital at home, there's no answer about what acuity tool they're using or whatever. But if Connie, if you want to speak to it, or
Well,
anybody else.
Nykole, my question is, when you use the word acuity, what do you mean?
Oh, got it.
I don't know what it means. I don't know what it
Oh,
means.
sorry. So
I'm not
sorry.
in
That's embarrassing.
not in the healthcare. I'm in health insurance, but I'm not in health, so I don't know.
Got it. So sorry. Yeah, that I try to never use words that people don't understand outside of it, but so apologies for that. Acuity is just like how sick somebody is. So a high acuity patient would be somebody who is sicker or more ill and needs more care. And a low acuity patient would be somebody who's doing okay and, you know, doesn't require that much nursing care.
Okay, thank you. The other thing is the reimbursement rates. You had mentioned that during COVID, hospitals will get reimbursement rates for people going into the home, for VNAs going into the home. Is that reimbursement scheme still around, or did they pull it?
Yeah, so the hospital at home Medicaid waiver is still around. And, you know, some people are worried that there's a risk that it will be eliminated under this administration. Whether or not that's a good thing sort of depends. Because again, this is about having people cared for in their homes as if they were inpatients. But it does still exist for now.
So prior to COVID, hospitals were doing this. I mean, patients would go home and they would receive care. So was the reimbursement rate different pre-COVID, like a lot less, and now it's a lot more?
It's actually, so it's a different thing because the thing that people typically, the kind of care that folks typically get at home after being released from the hospital is from a visiting nurse. And those patients have been discharged from the hospitals. The patients in the hospital at home program are still considered admitted in the hospital, even though they're at home. So that reimbursement rate is higher because, you know, an inpatient is by definition more acute than a patient who is discharged to go home. Does that answer the question?
Sort of, but so I'm going to I'm sorry, I'm going to dig a little deeper because I'm trying to understand it. And this is when we're really trying to understand the financing of hospitals and how they're making the money that they're making, which is extraordinary. The amount of money that they're making off the federal government is extraordinary.
Yeah.
So for instance, say a procedure pre-COVID that was reimbursed for doing something in home, did that same procedure go up after COVID because now it's based on if you're in the hospital? You know, do you catch my drift?
Yeah. Okay. So I'm going to split this into two things. So the first thing is that hospital reimbursement rates increased regardless of, let's not think about the hospital at home example for a minute, but hospitals saw increased reimbursement rates from Medicaid and Medicare during COVID. And that was because some of those reimbursements were about caring for actual COVID patients. And because they were such intense patients to care for that required lots of staff and personnel and procedures, hospitals got a bigger bang for their buck per COVID patient. They also just got additional cash from the federal government because, you know, hospitals had to cancel elective surgeries or less, you know, critical needs, less emergent things. They would cancel those procedures and services. And so the federal government said hospitals are going to lose a ton of money because they're canceling their, you know, their most lucrative procedures. And so we'll give them a little bit of extra cash. So that's how that worked for the reimbursement rates. Now the hospital at home thing is still a very small percentage of services in Massachusetts. I do think that will change over time, but the reimbursement rate there is the same as if the patient was in a hospital. So if you're at MGH in a bed and the reimbursement rate is X, and then you're an MGH patient who's still admitted but is sent home to be cared for in Newton, your reimbursement rate is still X.
Okay. Is the reimbursement rate the same for Mass General as it is for St. Luke's and New Bedford?
No, it's not.
Procedure? So it's a lot higher with MGH because it's in Boston.
So it sort of depends, like, St. Luke's is part of, a smaller healthcare organization or system, but still a multi-hospital system. So you'd have to I can look at the actual reimbursement rates, but generally, my guess is that the rates would be considerably lower at a St. Luke's than an MGH or the Brigham or something like that. But it's also not just a general reimbursement rate, it's also per diagnostic related group. So per service or procedure, it might cost $1,000 at St. Luke's. It might cost $2,500 at MGH.
Okay.
So there's a big difference.
Okay. What is the basic difference now between Medicare, Medicaid reimbursement rates and private health insurance?
So I don't know. I don't have a percentage. I don't know if anybody else does, but generally the way hospitals tell this story is that Medicaid and Medicare reimburse hospitals at less than the cost of actually caring for a patient, and that they need the private health insurance companies to come through with higher reimbursement rates for patients who have health insurance to cover the cost of not only their care, but also the care of Medicaid and Medicare patients.
So this is going to be a big issue transitioning from private health insurance to single payer. This is going to be a gigantic issue. And whatever ideas you have, resources available that we can read and look at to understand that relationship better. Because it's just like I'm a union negotiator. I worked with the UE for 35 years and
Okay.
I negotiate a lot of contracts. And there was always stuff that the employer or the broker would tell, the lines that they would give us that I didn't believe for a second. But we wouldn't believe, but those were the lines that they would use by why this procedure went up so much, why this is so much, why this copay is. It's a question that we've actually asked quite a bit over the last year, and we haven't gotten any clarity on about reimbursement rates. My understanding is Medicare reimbursement rates used to be higher than private health insurance not too long ago. And then there was a shift in the industry. Don't know why, but that there was a shift and now they're less. So if they're less, to be, for us to be able to understand that relationship, because that's definitely once single payer becomes getting traction, it's these kind of questions that the industry is going to come out with saying, no, it's not possible. It can't happen. Yet that we don't get the reimbursement rates. Okay. And then reimbursement rates is it per hospital or is it by region? Like Southeastern Mass, Boston geographic area, Western Mass.
It's per hospital, and per procedure within that hospital, but the parent organization and the larger hospital system that hospital is a part of plays a major role. Like a small independent in rural Western Mass. Well, we don't have those hospitals, but if we did, that hospital would, I'm sure, have lower reimbursement rates than an urban Boston academic, medical center affiliated with MGB.
Okay. And then I have one final question for me. Is there any particular book, document, a paper that's been written to give us a better handle on this particular question that you can, if there's anything you come across, and you could just give it to Sandy, somebody so some of us could look at it, have a better handle on it, that'd be helpful.
Okay. Yeah, I can look at that. I felt for a moment like I was on the Ezra Klein podcast. I really liked it. I don't have a book recommendation, but I'll look.
Yeah, I don't listen to Ezra Klein. I'm not a big fan of his politics, but that's okay.
Chris and Osa, do you have questions?
Yeah, I have two comments. I twice was chairman of our physician hospital organization, so I was in on the contracting, and some of the contracts are on a daily basis, and some of them are like DRGs where the Medicare pays for a certain amount for the diagnosis. Therefore, an early discharge is always in the hospital's best interest because they've already gotten paid a certain amount based on the admission. I also advised Cooley Dickinson in case management for 10 years. So there's always been this interface between you want to get out of the hospital fast because there's infection, there are various risks, medication errors, all sorts of other errors. But as long as the patient needs hospital care, they should be staying there. So the whole idea of hospital at home with reimbursement at hospital level makes zero sense to me as a practitioner. If the patient needs hospital care, is it just a technological thing that they can now send home with the patient? Because you don't have the personnel to support that. And if you require hospital care, you require hospital care, period. There's an interface in deciding that and deciding when the patient is able to go home. That's always been difficult and fractious, but hospital at home continues to make no sense to me. I put in the chat, what are the outcomes with hospital at home? It can't be very good. I'll shut up.
No, I mean, I share all of, I'm not a medical practitioner and but I am occasionally a patient and I share all of those same concerns. And, you know, the MNA, we did have somebody come from the UK, and the UK has some version of this hospital at home that's been in operation for quite some time. And she came and gave a presentation on it, sort of how it works there and how it works, how, you know, the US is sort of just kind of taking that and doing our own, probably worse version of it here. But yeah, I think the outcomes are a major issue because while like a VNA, nurses and other healthcare professionals like OT, PT, whatever you need, will theoretically be sent home. There are all, you know, to take care, sent to homes to take care of patients. There are all kinds of factors that you just can't account for. If a patient gets, you know, if a hospital gets the inpatient reimbursement, to my mind, they should be providing inpatient care. So it's pretty bonkers. Yeah. Shelley?
Yeah, just
Nykole, just excuse me. Deborah had a question, got lost in the
sorry.
chat, and then Shelley. Is variable reimbursement rates true for Medicare?
Oh, yeah. So good question. I don't know I can't give you like actual numbers, but Medicare reimbursement is different based on like region of the country and that sort of thing, but it's not different in the way that private health insurance is when it comes to like, you know, who owns you. So an MGB hospital isn't going to automatically make more than a small independent because they have more market power from Medicare, because Medicare just doesn't have to care about that. They're like, this is the Northeast, you're getting X for this diagnostic related group, something like that.
Shelley.
So just one thing to add on to what Chris was talking about. There's this thing, you know, called observation status, which is this limbo land where you're not inpatient, you're not outpatient. It's always been shady in terms of reimbursement and the effect on individual patients. They end up paying if they're on Medicare, if they're observation. How or does this status still exist, and how would it affect any of this, or is it the home status thing?
So I can't think of off the top of my head how that impacts the home status, but yes, I've definitely still heard recently that the observation status is still an ongoing issue, that people are still being charged when they're, you know, in an ED for multiple nights, but aren't necessarily admitted. We also have a related issue in Massachusetts. So Massachusetts right now leads the nation in the number of or in the occupancy rate. So we have more patients in hospital beds than like anywhere else in the state right now, you know, per capita or per bed. And we also have a huge crisis of so many patients being boarded in EDs for days, weeks, I mean, just a crazy amount of time. And at St. Vincent, for example, the hospital owned by Tenet that I mentioned earlier, I mean, that's an example of patients who are critically ill being stuck in an observation room, but not assigned a nurse, and dying because, like, you know, they're not actually being cared for. They're just like, you're over here, you know, we'll get to you when we get to you, if we get to you. And then, you know, I don't know, just the lack of oversight and the lack of eyeballs on patients is a nightmare for nurses and it's a nightmare for patients.
Observation status is on the way into the hospital before admission. Hospital at home is on the end.
Right.
Well, also observation status is not necessarily on the way anywhere. It could be just the status you're in, and then
That's true.
you go home.
Right.
Yeah, Kimberly had a question.
And I just, as a matter of fact, because I had a post-surgical infection and had to have I was offered 23-hour observation after my surgery without actually being admitted to the hospital. It was a weird thing. Well, but I'm wondering, this in-home nursing, would that be without Medicare? Because unless you're Medicare age, you can't get in-home nursing paid for.
Oh, so yeah, this is a different, let's see. Yeah, so I think right now private payers are paying for it, as far as I know. So it's not just Medicare or Medicaid, which, of course they're paying for it because it's part of a waiver that the federal government created, but I believe private payers are doing it too. And we've seen, at MGH, for example, this hospital at home group that just organized their first union, they've seen their ranks really explode, which I think is a signal that, if MGH is like, we better like ramp up, get, hire more staff to provide more of this care. I think it's a signal for the rest of us throughout the state that this, type of services or type of program is like kind of coming at all of us.
Thank you, Nykole.
Sure.
Yeah. Oh no. Yeah, Nykole, is it okay if we run over a little bit if we still have questions?
sure.
Peter, go ahead.
Yeah, just as an analogy, I sort of look at the what's happening with going into the home instead of staying in the hospital, similar to what happened with deinstitutionalization back in the 80s in Massachusetts, where they shut down almost all of the state hospitals and put everybody into group homes with no union.
Mhm.
And it was horrible. It was horrible for the parents. I know a couple of parents whose kids were in those facilities, and it was just horrible. And I think, although you would think on one level, a transition into a home-based setting would be beneficial for a lot of people, but the way we always go about it is based on money. It's not based on care. It's not based on what's best for the patient. So we always inevitably really screw it up. But I kind of agree with you. I think this is going to be an accelerating. I think this is going to accelerate. They're just going to keep doing more and more of it because I think it's just the best thing since sliced bread without much thought.
Well, and you're right. I used to work for SEIU 509, and we represented a lot of the group home workers who, work in those community-based settings. And I've thought of the same analogy, maybe not as crisply, but it really is similar because, there are some there continues to be some state operated inpatient facilities for folks, and those are union jobs and people are paid appropriately. And, there are all kinds of issues still, but, those are good jobs. And on the community side, I mean, I think the way VNA nurses are paid far less than inpatient acute care nurses. And the rationale for that as well, they're not doing as much, even though it's really much more high level nursing in the homes than it would have been like 20 years ago. I think that's kind of the same thing they're trying to pull, or will try to pull, with the hospital at home, will be to isolate workers out in the community away from each other. They'll just be visiting homes all day. They won't be in the same place and able to connect. And, it's hard to organize group home workers. And it'll, I think, be a similar fight for the hospital at home. But so far, I mean, we've seen some real success in Massachusetts doing some of that organizing. But I think your fears are right.
What's the wage differential between a VNA nurse and a nurse in a hospital?
Oh, that's a good question. That's a hard one. So I look at wages at every MNA facility and some non-union facilities and VNAs and home. And I don't know. It kind of depends on lots of factors, like Western Mass nurses in general are paid less. But then if you look at our Western Mass MNA contracts, the inpatient acute care nurses are certainly paid considerably more than a visiting nurse. I would say like a $10 difference, maybe
Okay.
something like that.
Yep.
And I would guess that those, if you looked at like a Boston area differential between, or not differential, difference between an inpatient acute care setting and a VNA nurse, I think it would be actually even a bigger difference.
Okay, thank you.
Sure.
Well, that may be it. Thank you so much, Nykole, for coming and for being available to us in general.
Happy to be here. Yeah, this is fun. It's nice to see so many faces I recognized and new ones. It's great.
Yep.
Have me back.
Little reunion.
Yeah.
Yeah, well, this task force, as I put in the chat, is called the Hospitals Task Force, but we have other intersections with the whole question of the industry, medical industry. And the nurses, of course, your union has been vital to the success of the single payer movement and to our understanding of the opposition. So I think there's ways to get you back.
Yeah, sounds good.
And when we have you, we will advertise it widely as we did this meeting.
Great. Thank you, everybody. It's nice to see you.
Okay.
Thank you, Nykole.
Thank you for coming, folks.
Thank you.
Thank you,
Bye-bye.
patient.
See
Thank you.
around.
See ya.
Okay, I guess we can turn it off.
Yeah, yeah.
The